Just to pop on and say we're live now, Mariano. So you can do your intro and welcome everybody in.
All right, brilliant. Thank you, Chloe.
Thank you.
Hello, good evening. Hi, I'm Dr. Mariano. I'm a consultant at the Care Fertility Leads. Would like to welcome you all here today. And we'll just do a quick video about our clinics. And then I'll go through a few slides. And then, of course, at the end, I'll be happy to answer any questions.
Family. It's who we are and who we're always going to be. It's the important little moments, the big emotions, the beating heart at the center of our world. It's the journey that we take there, together, one step at a time. Family is the one thing we'll always care about the most, because we believe that family is for everyone. And through our care, we'll do everything we can to make your dream real. We don't just care, we are care.
My name is Professor Charles Kingsland, and I'm the Group Clinical Director for Care Fertility. At Care, our number one belief is family for everyone, and this means we do everything possible to help everyone start or grow their family. We know that nothing is as important as family, and that's why we care so much about wanting to give every patient that comes to us their best chance of having a baby. Of course, families come in all shapes and sizes. We get heterosexual couples, couples of the same sex. We get single patients wanting to start a family. We get NHS patients. When you have a fertility problem, there should be facilities available for you to get the best advice and the best treatment readily available to give you the best chance of having a baby at a time in your life that is best for you. We will use all our knowledge and experience combined with highly individualized treatment, personal treatment, to help you have the family you are longing for.
Unbeknown to Gemma and I, we both carry a gene, a deafness gene. We actually have a daughter who was 3, but who was born prematurely deaf. And we were given the option and chose to go down a fertility treatment to kind of avoid our second child having that same gene.
We were very lucky in the fact that the clinic was only down the road from us, so we felt there was one around the corner. It had good reviews. We just felt it was good for us, didn't we?
The whole package made us just feel really comfortable that actually going with Care was the right decision.
So the team that we worked with at Care were unbelievable. They were caring, they were sensitive, they were compassionate, empathetic, and even when I was ringing out with I was feeling pains down one side, that the reassurance that they gave me, they honestly do hold your hand every single step of the way, and I feel like they lived the journey with us.
So I've had several treatments with Care, and I now have a baby, and that's taken a number of treatments, fertility treatments, different alternatives, different medicines to try and get it to work for me. I have always said I would recommend Care Fertility. I would recommend them for the comfort factor that I received, the friendliness, and just I think the word is my faith in Care Fertility.
Thank you for watching that video. I've watched the video a few times now because in a few presentations, and there's testimonies always to strike a chord in the heart. Now, I'd like to talk a few words about our clinics. So I work in the clinic in Leeds, which you can see here in the north of England, but we have multiple sister clinics all the way around. In the north of England, we have Manchester, Sheffield, Nottingham, and Cheshire. And as you can see, we also have clinics in the London Wales area, and in Northern Ireland as well. And then we have a few sister clinics in the US and Spain, in case any of you might be traveling there by any chance. So we are a truly international group. The first stage when it comes to fertility is really finding out what the diagnosis is, because when you get the diagnosis, then we can really get the steps going forward in terms of what is the right treatment approach, and also helps us give you a more accurate prognosis of what the different approaches might give you in terms of your success rates. And there are 3 key linchpin tests when it comes to fertility. And apart from this, there are other investigations which might be needed, but essentially these 3 investigations are key investigations. The first, for the 2 tests for the female partner, 1 for the male partner. The 2 key tests for the female partner are, one is a blood test called AMH. Now, AMH is a chemical which is produced by immature eggs in the ovary. And what it gives us is 2 things. It gives us an idea of how your egg reserve is, which is very important. Whether or not you're planning for a child now or in the future, it might be useful for you to know that, so that it helps you to make up your plans and your pathway accordingly. And secondly, from an IVF setting, it is quite a good marker to predict how the ovaries would respond to the injections we use to stimulate them. So those are 2 key things of the AMH provides us. And secondly, second test for the female partner is a pelvic ultrasound scan. And essentially, we look at the uterus, we look at any problems in the muscle of the uterus like fibroids, any issues with the lining of the womb, and then we can look at the ovaries. We can see whether any problems in the ovaries, any cysts on the ovaries, and we can also do an assessment of ovarian reserve by looking at the ovaries called the antral follicle count. Next, for the male partner, there's 1 key test, which is the semen analysis. And the semen analysis is the 3 main things we look at are how many sperm there are, that's the concentration, how many sperm are moving forward in a straight line, that's motility, and how many sperm are normally shaped, that is morphology. We've had a question about what's considered normal and abnormal. The WHO sets out criteria to say, what's the cutoff for saying something is normal or abnormal. Now, it's very important before I say these cutoffs or these numbers that, a number below this doesn't mean a pregnancy can't happen naturally. It just means a lower probability of pregnancy happening naturally. And the lower the level beyond the cutoff, the lower the chances of conceiving naturally. So you look at the concentration, we hope to see 16 million sperm in 1 ml of the fluid. If we look at motility, that's progressive motility, sperm moving straight forward. They're like 30%. We expect them to be straightforward swimmers. And morphology, the proportion of sperm normally shaped, we expect 4% sperm to be normally shaped. 4% might seem quite a low number, but that's because extremely strict criteria are used to determine what's normal. And so that 4% is the cutoff of what's considered normal. When you've had all these investigations, it provides really the information which can be used to discuss with you at the consultation, taking into account your medical history, taking into account any previous treatment you have had, taking into account what your wishes are and how you wish to go about building your family, and allows us to really tailor the plan to your circumstances. And we have a patient portal which is available through our website, which is also mobile friendly, and this is the main document system through which you send your letters, information, and so forth. Now, I really like this picture because it in one single picture it summarizes everything which happens in IVF. So if you start in a clockwise way from here, this is really the first stage where you do the ovarian stimulation and egg retrieval. I'll explain that in a minute. And then once we get these eggs, we get the partner sperm, mix the sperm and the eggs together in the lab. That's IVF. So IVF actually stands for in vitro fertilization. I'll explain what that means. The last word, fertilization, stands for getting the eggs and the sperm together. In vitro means it happens outside the body. So basically the sperm and eggs are mixed together outside the body to create an embryo. That's IVF. So this one picture is what represents IVF. And then once the eggs are fertilized by the sperm, they're kept in the incubator, and then the embryo is transferred back into the uterus through the cervix. Next, coming to the IVF process, I said I'll discuss about what ovarian stimulation involves. It essentially involves giving injections. These are subcutaneous injections, are really fine, thin needles. It's just go in your tummy, just below your belly button or slightly right to it. And then these are daily injections. And we have excellent videos on our website which go through each of these injections in more detail. These are screenshots from one of those videos which explain this. Then we come to the IVF process. In this, we do the monitoring. So before this, we have discussed about the injections to stimulate your ovaries. We need to know how your ovaries are responding to this medication. And the way we do that assessment is by doing scans. And scans can let us know how the ovaries are responding. And also, it gives us an idea of when is the right time to do the egg retrieval, which brings me to the egg retrieval slide. Now, egg retrieval involves passing a needle through the vagina into the ovaries under pain relief, of course, and then we get those fluid from the ovaries. So in this picture, you can see a needle going into this black structure, which is basically fluid containing area in the ovary, where we drop the fluid, pass it to the embryologist, and they look under the microscope and isolate the eggs. Simultaneously, the sperm is prepared. So if the partner is providing a fresh sperm sample, they'll be doing so on the same day of the egg retrieval. This is a slide showing how the fresh sperm sample looks under the microscope. You can see sperm there, but there's also some debris and so forth. And what we need to do for IVF is to prepare the sample, take out all the debris, and only get the good healthy sperm there, which we can then use for IVF. Now we analyze the sample so that we can see how many moving sperm there are in the sample. And that is quite a key indicator for us to find out whether IVF or ICSI is needed. The indication would have been made long before when we had the semen analysis report to hand. And also in this circumstance, outcomes of previous treatment, or if someone has had pregnancies before, also becomes key to finding out whether it is ICSI or IVF, which is recommended. But a plan can be made before, but the plan can be obviously updated depending on the sperm sample. So let's say, for instance, the plan is made for IVF, but the sperm is really not suitable for IVF on the day, then we go for ICSI. Whereas if the plan was initially for ICSI, but let's say the sperm is really much better, let's say someone's made really great positive lifestyle changes, or sometimes it can be just coincidence to a certain degree, and the sperm is really much better, you don't need ICSI anymore, you could have IVF. After the eggs have been retrieved, there's fertilization which happens. And this is the ICSI process for fertilization. I showed you the IVF process for fertilization in this picture, where you just let the sperm bind to the eggs naturally. ICSI is where we take the sperm and inject into the egg. So it's a bit invasive. Obviously, we have the best embryologists working with us. But yes, here's a lovely video of ICSI. So that comes the pipette, injecting into the fluid. It's a jelly-like area inside the egg, and there goes the sperm. Sorry, here goes the sperm inside the egg. And basically, this is how the ICSI process takes place, where the sperm is injected into the egg. Thank you for that video. So that's the ICSI process. We can also do IVF, where we let the sperm bind to the eggs naturally, and then we keep the embryos in the incubator and keep them for culture. Conventionally, nowadays, we keep the embryos for culture for 5 days because that gives us the maximum amount of information about the embryo development and helps us really to select the best embryo for transfer and make sure we're not transferring embryos which have really no chance of implanting. So if they've gone till day 5 and grown till day 5, they have the potential for implantation within themselves. We also have the Care Maps algorithm, which essentially monitors how the embryo has grown and developed. So embryo starts off as a single cell, and by the 5th day of development, there are around 200 cells in it. This is a video showing how the embryo grows and develops. So there's a constant process of splitting and organization. So these cells look quite similar initially, but by the end of this video, you can see they have consolidated into 2 different groups of cells. The cells outside are what form the future placenta, and the cells, this mass here, is what forms potentially the future baby. And they start to hatch out of the shell as well in preparation for implantation. So that's the time-lapse video. It's basically, if you see these nature documentaries like Green Planet, they show you a plant growing from a seed, and that's basically multiple slices of pictures compiled into video. Similarly, we are able to compress the embryo's journey over 5 days into a single 2-minute video by using the same technique. But more than it obviously gives a very good video, which is important for people. They might feel they would like to see the embryo's development and have a copy of their record of the video as a personal memento. But apart from that, from a scientific perspective, this process of development, where it goes through different stages, when it is captured, it's called morphokinetics. So essentially what we're doing is we are looking at how the shape of the embryo changes. We're looking at how the cells are dividing, the regularity of the division, the evenness of the cells, and whether there are any fragments. These are the 3 main things. And when we're able to consolidate and provide a picture of how this has happened over multiple stages of division, we are able to build up a picture of the embryo's journey. This map can then be inputted into the AI algorithm to provide a potential score of implantation of the embryo, where embryos which have done extremely regular divisions will score higher, and we know those embryos have a higher chance of implantation. The embryos which have not done so much regular things cannot say because some of them can adapt and catch up, but inherently they might have a lower chance of implantation. So this has been published. There have been multiple publications on this, and it's also got the IT industry awards recently. That's quite an innovation. Then if obviously we transfer an embryo, but you may have extra embryos suitable to freeze as well. And embryo freezing has really revolutionized how we do IVF. Even in the span of 15 years when I've been doing IVF, the embryo survival rates have gone up from 70% to what's now quoted as 98.5%. So orders of magnitude much, much better. And nowadays, conventionally, we say the fresh and frozen embryo transfer success rates are practically the same. Pardon me, I just have a bit of a cough, so that's my voice is a bit gravelly. Next stage is the embryo transfer, where we transfer the embryo in the catheter back into the uterus. Embryo transfer procedure is done as an outpatient process, like a smear test, involves passing a speculum and a catheter through the cervix. IUI is also another option. Now, IUI is artificial insemination. And the primary reason why we are now using IUI in my clinical practice, or our unit's clinical practice, is predominantly for those using donor sperm treatment. There are some circumstances where IUI can be helpful for couples as well. They have difficulty having sexual intercourse, or it is causing stress for them. But the predominant reason, as I said, we use IUI nowadays is for donor sperm. And it is a very good tool for that, excellent success rates. Shared motherhood is where, in a same-sex couple, one partner provides the eggs, they fertilize with donor sperm, and then their partner carries the pregnancy. And essentially, this allows both partners in a same-sex relationship to go through treatment, whereas otherwise, for example, if other methods of your treatment with donor sperm, such as IUI or IVF, involve only one person in a relationship, whereas shared motherhood allows both partners to take part. Now, we have a huge need for donors, and we have our own sperm and egg banks, because quite a good number of our patients do need either donor sperm, donor eggs, or both. And we have a dedicated donation team who have good relationships with multiple sperm banks nationally and internationally, who can provide these services. Now, you might have a different sperm bank in mind, and if so, we can check whether sperm from that sperm bank is compliant with UK regulations, because we can only import sperm which are compliant with UK laws. We have very good egg donation services and very good success rates, and we have a good number of donors available who have frozen their eggs. So basically it's like an egg bank. And obviously the entire treatment process for you will happen within the UK, and that obviously avoids need for travel and so forth. Now, we also have people. There are two types of donation, essentially. The one is anonymous donation, the other is known donation. Known donation typically occurs when people wish to maintain a genetic link. For example, if it's a sister donating to a sister, or a cousin donating to a cousin, and so forth, where they hope to maintain the genetic link. And if that is something a couple would like to do, then that is a service also that we can offer. We are the National Surrogacy Awards winner. And surrogacy is an incredible tool, especially where otherwise someone cannot become a parent. And it can be, however, quite legally complex. Donation is quite straightforward in that way. The birth mother is the legal mother, and the partner of the birth mother, provided the appropriate forms have been signed, is automatically a second legal parent. If they marry, they automatically a second legal parent. If not, we do the appropriate forms, then they are. Surrogacy is a bit more complex from a legal parenthood standpoint, although the government has made lots of efforts to simplify the process. But we have a dedicated surrogacy team who can support every step of the way. Next, about surrogacy, we have the two types of surrogacy. One is gestational surrogacy, the other is traditional surrogacy. Gestational surrogacy is where it's donor eggs or donor sperm and a surrogate. In other words, the person carrying the pregnancy in a surrogacy arrangement is called a surrogate, is not genetically related to the baby. So it's either one of the intended parents, they have provided their own gametes. Please note, for UK surrogacy law, one of the intended parents. The intended parent is the person who will for whom the treatment is happening, who want the baby. Or one of them need to be the gamete provider. So either the sperm or the eggs. Traditional surrogacy, basically it is like artificial insemination, where the surrogate is also the genetic mother. Generally, in my experience, gestational surrogacy is what we do. We also have counseling support available, and because it is quite a complex process, and our team are here to support you every step of the way during this treatment journey. This says every step of the way there. And we have an inquiry team, care resource, which I mentioned. The care portal is a fantastic source of resources. The websites have lots of information, injections, and so forth. The care pals team, the care forum, counseling, and also the social media, where we provide regular information and updates. There's also a care pay option available, which is essentially like multi-cycle programs. And if you're interested in something like what these options are, then you can obviously contact our administrative care pals team about it, and they can signpost you to the relevant information. Thank you for your questions. I've had some questions already. I'll just go through some of them. So about PGTA, that is genetic testing of embryos. I'll just go back a few slides to show what PGTA, where it happens. So you have the embryos develop, and we can biopsy the embryos at this stage. where the embryo has split into two sort of cell stages: the cells outside, which form the future placenta, cells inside, which form the future baby. We biopsy only the cells forming the future placenta, not the cells forming the baby. And this is very important because it makes the procedure quite safe. There's no increased risk of preterm birth or low birth weight or anything like that. So in that sense, it's quite safe. And these cells from the biopsy are then analyzed. But because they are from the placenta, this testing can never be 100% accurate because we are indirectly inferring what's happening in the embryo. So that's always a limitation, which I say it can never be 100% accurate because we are not biopsying the embryo, we are biopsying the placenta. So there's always that factor there. Asked about what are the indications for PGTA. Well, there are different reasons why people go for PGTA. I'll go through a few reasons and the circumstances in which someone might consider them. There are obviously no one-size prescriptive approach for everyone. Each circumstance is complex. So one of the advantages of PGTA, I'll tell you what it does and what it doesn't do. PGTA essentially helps us to find out if the embryo is genetically normal or abnormal, because that's one of the key reasons why the success rates are not 100%, because some of the embryos are genetically abnormal and the incidence of genetic abnormality increases with age. So, for example, if you're in your early 30s, only 1/3 of the embryos will be genetically abnormal. Whereas if you're in your late 30s, that ratio shifts like 2/3 being genetically abnormal. So there's a shift there. Late 30s, early 40s, to be more precise. For example, if you're 42, 43, then over 80% almost are genetically abnormal, depending on the test used and depending on the circumstances and so forth. But that's a general rule of thumb. And that's one of the reasons why the success rates go down. Sadly, the risk of miscarriage and Down syndrome increase. And genetic testing, like this genetic testing of embryos, can essentially help us to identify which embryos are genetically normal and which embryos are genetically abnormal. And by transferring only genetically normal embryos, we can essentially eliminate the age-related increase in the risk of miscarriage. There's obviously a background risk of miscarriage, which is not age-related. You might have a miscarriage even in your 20s. That can never be eliminated, but we can reduce the age-related increase in miscarriage by using this technique. Now, what it doesn't do is that it doesn't make the embryos better. So, for example, let's say you have two embryos, only one of them is genetically normal. Well, genetic testing is not going to make the other embryo genetically normal. It's just going to allow us to choose and tell you which of those embryos are genetically normal. Whereas you might say, actually, I'm not going for genetic testing. I'm just going to transfer this embryo first and then have a frozen embryo transfer of the other embryo. Well, you would essentially have the same chance of having a baby as biopsying and finding out which one is normal. It is quite a strenuous process for the embryo to go through. And your particular clinic will be able to tell you based on their experience what the survival rates are and so forth. So that is another factor. So because of those factors, it's quite a nuanced decision on who's best served by it. Generally, someone has had recurrent miscarriages, multiple failed IVF cycles, and in circumstances where someone is, let's say, on the older side, but an excellent egg reserve, where we're expecting lots of embryos, and we really want to save them time. So, and we want to do it in a safe fashion. So, for instance, let's say someone is 41 and they have 7 embryos, which is quite a good outcome. If you're 41 and you have 7 embryos to be frozen, that is fantastic. But it also creates a dilemma. Do you transfer those embryos one at a time, which is the safest approach? Well, then you're using up almost a year. Whereas, let's say you are transferring them 2 at a time to cut down on time, but then you're taking risk of twin pregnancy. But what we can do is biopsy those embryos, and we know, okay, 1/5 of those will be normal. So out of the 7, maybe 2 are normal, and you only transfer those. And that way, you're saving time, you're saving unnecessary heartbreak, and if used in the right way, it's actually cost effective as well. If you think about it, if you're saving on unnecessary frozen embryo transfers and so forth. So it's really a fine balance on who would benefit best from it. Another question we have had is about freezing eggs versus freezing embryos. This is something my special interest is actually patients freezing eggs or embryos before cancer treatment? And this is a question I get asked all the time. So I can tell you with the fair degree of confidence on what I counsel people about this question. Now, eggs have a survival rate of 80 to 90%. Embryos have a survival rate of more than 95%. So if it was a question was only efficacy, embryos would win. But there is a catch, and the catch is that eggs allows you to preserve your reproductive autonomy. They're your eggs. Nobody can say what to do with them. Whereas if it's embryos, then because it's a couple, if you were to split up in the future, which I sincerely hope not, but we have to be pragmatic. And there have been court situations where a woman froze embryos before having treatment for breast cancer. Then sadly they split up, and when she was not able to use the frozen embryos anymore. So especially in my field, where I come across people who might be using those eggs or embryos only 6 years down the line, once the cancer treatment has passed and they're recurrence free, I always ask them to consider that as a possibility. And because if they froze embryos, yep, the survival rates are better, but if you split up, you can never use them. So that's really the delicate quandary there. So generally my recommendation is egg freezing. But if someone said, I appreciate fully all the caveats you're saying, and we want to freeze embryos, I wouldn't stand in their way and say, no, you can't freeze embryos. But that's the general reason why we suggest egg freezing. Coming to some other questions, success rate prediction. Pardon me, just 1 minute. Oh, yes. We have an AI system which uses images of the eggs to predict egg the chance of the egg surviving, forming a blastocyst, and so forth. And using that information, we can say that you have an X% chance of having this many number of embryos from these frozen eggs. So that's a really fantastic tool we have, and that's also been submitted for publications and so forth, because I think personally that is one of the best tools, because it gives you an idea of what you have in storage. It allows you to know, okay, I have 24 eggs in the storage. What is the average number of embryos I would hope to get? And those embryos, each of them, what's the chance of them implanting, which we can tell you by use of tables we have from years and years of success rates. And that is available through our Egg Safe AI package. If you're under 36, a good egg reserve, BMI is less than 35, again the exact criteria there on the website, you would be eligible for that. And that's something I do discuss with patients who are thinking of freezing their eggs, let's say in the early 30s. The early 30s are really the best time to freeze their eggs. It's not that you can't freeze your eggs afterwards. For example, in my primary focus in onco fertility, we come across people who might be in their late 30s or slightly early 40s, where you say, okay, fine, we can freeze eggs, but we need to know what your odds are of being of having a successful outcome with these. But so if you go for the Egg Safe AI package, it provides a lot of information which you can then use for your future. So other questions. Tests like endometrial tests, Emma and Alice. Now, Emma is basically microbiome testing. Microbiome are colonies of bacteria primarily, but also fungus and viruses, which live normally on all the surfaces of our body. So it's present on your skin, present in your mouth, present in your gut, even present in the lungs, present in the reproductive tract as well. And we are using this particular test, which looks at a biopsy from the womb lining and seeing what the microbial population is. And by ascertaining what sort of balance of microbes there are, we are able to individualize as to what probiotics to provide and so forth. Now, this is at present it would be wrong of me to say it is conclusively proven, because till now we are still awaiting the large-scale randomized trials to see its exact benefit in terms of quantum of benefit and so forth. The limitation we have with some of these upcoming tests is it's very difficult to pinpoint who is the person who's going to benefit from it. Now, hence we generally use these in circumstances where the conventional methods of treatment like IVF have been tried and the embryo quality has been very good. We can use the Care map system to find out, okay, we have tried IVF, your embryo quality is excellent, the lining of the womb looks good on scan, but nothing's happening. Should we look at some of these other things to see whether you are in that subset of people who might benefit from this sort of intervention? The problem is not everyone benefits from those tests and interventions when we still don't have a clear-cut way of identifying who is the person who actually benefits. Now, coming to microbiome is becoming incredibly clear from the works of Tim Spector and the Zoe research team, who are pioneers in this field, that many of the lifestyle factors, which we say like eat healthy, have good sleep, less ultra-processed food, and so forth, all of them, many of them have links to the microbiome. So microbiome doesn't necessarily mean only probiotics. It also means everything to do with your own general health as well. All those factors seems to have an outsized role on the impact on the microbiome on the longer term, rather than a short-term fix. Naturally. Natural killer cells, again, is something we don't personally offer in Leeds because it needs to really be done in a center which has, it's a very delicate test. We generally signpost people to Coventry if they're keen on having that from Leeds at least, but obviously there are different factors there. I saw a question about how do we determine what the NHS funding criteria are in my region. Well, all the funding bodies, they are called Integrated Care Boards or ICBs now. So in Yorkshire, we have the Yorkshire and Humber ICB. You also have the North Cumbria and so forth ICBs. If you look at the local ICB, they will publish publicly the criteria for fertility treatment funding, but your regional fertility clinic will be able to advise you because they would know exactly what the funding criteria are in the region. I think I've answered most of the questions. Right. Had a question about milder stimulation IVF. Again, it depends. Personally, I haven't really found the data very convincing. Okay, let me rephrase that. I would use a milder stimulation and see if someone's AMH was indicative of the risk of ovarian hyperstimulation. But that is the only indication I would use it. If someone's AMH said, okay, this person is going to be at risk of really high ovarian hyperstimulation syndrome, then I would use a milder dose of stimulation to mitigate that risk. Now, the problem is there is no agreed upon standard definition of mild IVF. Some definitions use stimulation doses of 150 and 225, which are doses I quite often use in my clinical practice. So in that sense, I am doing mild IVF in a way. But certain other situations where it is used is if someone has an AMH indicating that they are going to have a low egg yield, and conventionally I would use a higher dose of stimulation, whereas others might say, okay, we actually will use a lower dose rather than a higher dose. The fear was maybe when I was 20 years back, the fear was that a higher dose of stimulation might affect the chances of the embryos being genetically normal or abnormal. But now actually one of the benefits of PGT is not just a treatment tool, it's also a very good research tool. It just provides so much information about the embryo. And now, because we have been able to actually assess the embryo's genetics and not think hypothetically, there's a recent study which is actually titled "Dose of Stimulation Does Not Affect Genetic Potential of the Embryos." And so when we have studies like that coming out, and when we know that more eggs equals more embryos, to a safe degree, of course, because it's important, safety is paramount. I am not at present supportive of deliberately getting fewer eggs than what I would consider ideal to get a good number of embryos, because we know at the end of the day, more embryos means more chances essentially, and rather than fewer number of eggs. But I don't think the conversation is completely over yet about mild stimulation versus conventional stimulation. But I have not seen data yet which convince me about mild stimulation, and the available data is more and more strongly pointing to conventional stimulation. And I do say this with a certain degree of expertise on the subject. If you Google search my name, we actually did a systematic review and meta-analysis of the outcomes of mild stimulation versus conventional stimulation. And one of the reasons we did the analysis, we also did an analysis on, because there was a few analysis we did. Basically, we looked at chances of preterm birth and low birth weight. And while the chance of preterm birth and low birth weight were slightly lower with mild stimulation, what was also abundantly clear was the success rates were also lower. And the success rates were much, much lower than the reduction in preterm birth and low birth weight. And essentially, first we need to get you to have a successful outcome. We want you to have a baby. And so I am not as convinced about mild stimulation, less convinced now than maybe a couple of years back. Okay, thank you very much. And I do hope this was informative today. And we have a fantastic clinical team. I've talked about most of the clinical side of things, but we also have a fantastic research team. And much of the work we do in an ongoing process and getting you the best outcomes is based on research, which has been years in the making. And the research we are doing now will enable us to provide you better answers and better treatment outcomes in the years to come. So all the best, and I wish you all the best with your treatment journey. Take care.
I'm Shah, and I manage Care's new patient inquiry team. We're here to make it easy for you to take your very first step in your fertility journey. We completely understand how nervous and excited you might be when you contact us. This is the start of a life-changing process and hopefully the beginning of an amazing future as a family. So it's really important that we give you all the information you need. That way, we can help you to feel much more comfortable and confident with your treatment. Whatever you need to talk about, I want to reassure you that no question is silly or trivial. We appreciate that there might be a lot to take in at first, but don't worry, we'll send you a clear information pack about the treatments you're interested in, and we're always here for any follow-up queries. My team also manage inquiries about Care Pay, our range of funding packages which are exclusive to Care Fertility patients. When you're ready, we can book you a virtual consultation with a specialist fertility doctor from your local care clinic. So, if you want more information, have a question, or wish to book an appointment, call my team. We want you to know that we are here for you at every stage of your fertility journey. We say that our patients become part of our care family, and it's true. We care deeply about you and your future, and our teams are here to make sure you have all the support you need.
The reason why we chose Care was just, one, the care that they give you, the aftercare that they have available to you, and the fact that they offer different forms of treatment, and they listen to you. One thing that I've identified and what I've noticed when speaking to other people that I've met within the infertility community is there's a lot of clinics out there that don't necessarily listen to you as the patient. It was kind of a one size fits all, but with Care that didn't seem to be the case at all. They took everything into consideration, they listened to your concerns, they listened to you as a person, and they put a package and a process in place that will help you, and fingers crossed, will give you that positive result at the end of it. So without a shadow of a doubt, if I had to go through it again, I would definitely go back to Care.
Oh, the support at Care was brilliant, yeah. I mean, the nurses were brilliant for us. You feel so
looked after,
cared by the whole team. We felt that they did care, and it wasn't just for them getting something out of it. It was actually that
ongoing support.
Yeah, and they wanted it to work for us.
Care Fertility started over 20 years ago with one clinic and the goal of helping patients achieve their dream of family through truly personal care and the most scientifically advanced fertility treatments. We've grown from that one clinic. We now have clinics across the UK, and many people have become part of our Care family with over 50,000 Care babies in the world. But one thing has and always will remain the same. We care for each and every patient. We care about your dreams of having a baby, and we put our heart and soul into every aspect of what Care can offer you. To provide you with the best care possible and to give you your best chance of success and treatment, we look to our own Care family. From our consultants, embryologists and nurses to our admin teams and specialist fertility counsellors, we've also put a lot of thought into how we improve each and every step of your journey, which will no doubt begin with lots of questions. We know that thinking about starting IVF can be daunting for some, and that's why our Care patient services and support teams will always be there for you whenever you have a question, need advice, or simply want someone to talk to, so that you feel completely confident and in control of your fertility options. So yes, we have grown and developed over the years, but care and empathy are always at the heart of who we are. We are passionate about changing lives and creating futures, and I hope that this shines through in everything we do and everyone you meet at all of our clinics. We don't just care, we are Care.